Morning, everyone. This is our 12th Anpa financial webinar. Today, we are going to be discussing business planning and asset protection, the business and practice of medicine. I am your moderator with Dr. Susan Idionye, who will be joining us shortly. But before we can get started, we would like to have our Anpa National President, Dr. Chris Okunsuli, just talk to us about a little bit of Anpa.
Good morning. Again, this is Christopher Kunsari. I am calling from Milwaukee, Wisconsin, and on behalf of the Association of Nigerian Physicians in America, I want to wish each and every one of you on this call a Happy New Year. And not only are we looking forward to a Happy New Year, but we're also looking forward to a prosperous New Year. Our organization, Anpa, is a 501c3. We represent over 5,000 Nigerian dentists and physicians in America. And quite honestly, we pride ourselves in being able to engage our members in professional development, providing opportunities for leadership. We also, pride ourselves in getting engaged in the network so that our members can benefit from the practice referrals. We are very good at making sure that we are brother's keeper. And most especially, we actually conduct a medical mission every year. In addition to the medical mission, we are a strong group that engages in volunteerism in our different states or through our different chapters. So I want to quickly take this opportunity again to thank Stanley and his team and members of the panel for taking out time today on Saturday. I did hear Dr. Aloko say, Saturday is sacrosanct, this is golf day. So I appreciate him sacrificing today for the benefit of Anpa. So thanks everybody, and I would allow this conference or this webinar to start and look forward to a very productive and educational webinar. Thank you very much, everybody. Appreciate it.
Thank you very much, Dr. Kunseri. Next will be Susan Idionye, our membership chair. Susan.
Good morning, everybody. How are you doing? And happy 2021. My name is Dr. Idionwe. I am the membership chair. And I just wanted to take some time to reiterate a few things about AMPA. One, we want you to stay connected with us. As you have probably seen in 2020, there's been a lot of push to really communicate with our members. And we want you, again, to stay connected with us, following us on our social media platforms, as you can see there. We have AMPA email listservs where our members communicate. So if you're not a part of those, please know that they are in existence and you can be a part of that. Our website, which will be rolling out with an updated version very soon. You'll see announcements and calendar events telling you what AMPA's got going on. And most importantly, if you haven't already, our local chapters are really the heartbeat of AMPA. And this is a way you can connect with AMPA physicians in your community and AMPA providers in your community. So please look to connect with the local chapter. I also want to make everybody aware, if you've not already been made aware, that dues renewals have now begun for 2021. So please be advised, you'll be seeing some communication from us to renew your AMPA membership dues. They're very important to the growth of AMPA and to our future. So yes, thank you for that.
Thank you. Just a little bit of promotion for the webinar. We will continue the webinar on the first Saturday of every month. The entire year have been planned. It will start at 12 noon exactly, approximately an hour. We might go over when we have great information. The webinar, it will continue to be an intentional aggregation of subject matter experts. And we promise for it to be the highest and best use of your time. It is free to AMPA members, so please share this wonderful information. Just a little disclaimer. The materials presented at all Anpa webinar is for general educational information purposes only and is solely the opinion of the presenter. No webinar is intended to provide personalized financial or legal advice. It is left to the discretion and the judgment and is a sole responsibility of each attendee to determine what is necessary for his or her own practice. Neither the speakers or AMPA can be held responsible for the materials, opinion, or any inadvertent error or omission in the preparation or presentation of the material. Further, nothing in the material should be construed as an endorsement by AMPA. With that said, today we're going to be discussing the business planning and asset protection, the business and practice of medicine. Today is basically Ask the Expert, a roundtable panel discussion. We have our very own Dr. Yele Aluko, who was a past AMPA president. We have Herbert, who been here before, Mark D. Tondo, Owe, a good friend of mine, Amy, of course, everybody knows Amy, and I'll be moderating with Susan. I'm going to let Amy go forward next.
Thank you, Stanley. Thank you very much. Happy New Year to you. Happy New Year, Anpa. Welcome to our first 2021 edition of your Anpa Financial Education Series. As you know, our goal is to arm you with financial intelligence. Doctors, you're not the average American. You're not the average Nigerian. You're not the average wherever you come from. You're different and you earned it. You need to understand and embrace that difference. You need to pursue unique advice, specifically designed for people like you, not average advice. That's the purpose. That's the mission of the Financial Intelligence Series. Surprise, surprise, you're not the 95%. And most of you are not the 99%. Keep that in mind. Today, we have a beginning of the year Ask the Experts. It's a round table following a can't miss presentation from, as Stanley just said, one of you, an Anpa superstar. We have CPA and Certified Tax Master, Mr. Hubert McIntosh, whom some of you would remember has been tagged the most wanted tax man in America by the IRS. We have a retirement plan specialist and expert, Mr. Mark DiTondo, who's going to share important information about 2021 and beyond, retirement planning, information and strategies. We have estate planning, emphasis estate planning, business planning and asset protection attorney, Owe Bele. A number of you here know him, and hopefully a number of you have tapped into his expertise. Owe will share information and also answer questions about the all-important foundational issue of estate planning. If you look at the pie that is on the screen, there are 5 pillars in best practices. Each of these calls for expertise that's specialized if you're going to go deep in the woods. And that's what I mean by you are not the 95% or the 99%. You need experts in every single one of these areas: estate planning, tax planning, insurance planning, risk management, income planning, investment planning. Investment planning does not accomplish all the other things. Tax planning is one aspect of this. So you need all those things as a group. and in a team. After our keynote presentation, you'll have the opportunity to ask questions of our experts, and as Stanley said, for as long as you want. Today is Ask the Experts. A foundational member and founding member and past president of Anpa, a medical professional who has been purposeful and intentional in his career pursuits, and unquestionably is highly accomplished in every right and by every measure. He will share his uniquely vantaged professional observations and perspective on the business of medicine and the practice of medicine. Then, my friends, he will deliver invaluable advice informed by his incredible personal journey. He's currently the Chief Medical Officer for EY, a global institution. He's a cardiologist by specialization. He has served in numerous healthcare leadership positions, including as founder and president of the largest minority cardiology practice in the Charlotte area, North Carolina and the Carolinas. As president of the largest multiracial cardiology practice, just to name a few. He has been profiled as one of the top and most influential minority executives in healthcare, among many accolades. My friends, please welcome Dr. Yele Aluko.
Dr. Aluko.
Thank you very much, Enyi, for that kind introduction. I want to thank you, Enyi, your organization, Stanley, Susan, and the Anpa organizing leaders that have begun this webinar series, which is of significant value to our membership. I'm no superstar, I'm one of us. And if I am one of us, if I am considered to be successful, then all of us can be equally successful. I appreciate your comments, Enyi. So what I'd like to do today, having been asked by Enyi and Stanley to offer some thoughts, because Anpa is a very multi-variegated organization with multiple specialties, physicians and dentists, I wanted to choose some topics that would resonate with every person in Anpa. Nothing specialty focused, nothing that was business focused in a particular specialty. But I thought we'd talk about some political issues, such as the impact of the incoming Biden-Harris administration on the health industry as a whole. And I also thought that it would be of value for us to understand macroeconomic observations in the industry, and also to be aware of the ever-evolving megatrends that continue to provide opportunities within the industry, but absent of the insight could create significant challenges for others. And finally, I'll offer some personal perspectives. As Enyi has mentioned, I have practiced in the trenches, in the front lines, as many of the audience are still doing. I have been a physician executive, and I currently am a healthcare management consultant. So I'll share some observations in that trajectory with you. So with the Biden-Harris administration, which is yet to be inaugurated, but there's some truisms that we consider to be directionally correct. With the Trump administration, there were several reversals of important provisions related to the Affordable Care Act, Medicaid expansion, and preserving women's rights for decision-making on their healthcare. It is anticipated that several of these will be restored by the Biden administration with rapid intentionality through executive actions. In addition, the isolationism that has been the mantra of the outgoing administration in regards to healthcare partnerships globally, in particular the World Health Organization, it is likely that that is going to be restored as a significant, foundational, and pivotal partnership to further augment competencies within the health industry. We are all aware that the response to the coronavirus pandemic has been very marginal, to say the least. It is expected that there is going to be deliberate strategy behind the ongoing mitigation of risk with the pandemic, as well as execution of strategy for a vaccine rollout. We've observed that while we have a very strong healthcare industry by way of professional capabilities and competency, in other words, we have people that are working as physicians and nurses and other healthcare workers. Despite that, it has become very evident that absent of policy and absent of process, you can have the best people, but the product delivery is compromised. So expect the Defense Production Act to be reactivated, to ramp up all things that need to be coordinated to make a smoother experience and hopefully achievement of herd immunity with the pandemic. If you look at the regulatory actions, it is likely, again, that there will be reversal of certain waivers that the current outgoing administration has put in place. There's expected to be expanded availability of short-term limited health insurance plans, as well as enabling states to apply for subsidies within the Affordable Care Act. There's also going to be cutbacks that will enable more optimum affordability for prescription drugs that had been reversed by the Trump administration. Now, if you look at this slide, speaks to legislative scenarios that we at EY have looked at. My partners and I have access to information that's coming directly from the Hill. We have a business unit called the Washington Council, and these partners of mine in the Washington Council, they all live in Washington, DC. They interact on a daily basis on the Hill. They understand the thinking of both the Democrats and the Republicans and the independents, and are able to understand potential trajectories and help us advise businesses with some reasonable, directionally accurate projections. In a few days from now, we will know who controls Congress. But what you see here are scenarios whereby Democratic principles are aligned and Republican principles are depicted. If you look at the legend at the top right, the circle, the white circle demonstrates a very unlikely scenario, and the yellow fill circle is very likely. So if you go to the bottom of the slide, reducing drug prices, increased care and access for mental health, opioids, a focus on health equity and maternal mortality, and a focus on rural and underserved access to health and telehealth, you will find that there is close alignment from those five initiatives between both the Democratic Congress as well as a Republican Senate. So if we end up with a Democratic Congress and a democratically controlled Senate, it is likely that several of these from the top to the bottom will come to pass. But if it is still a Republican-controlled Senate, we're looking at the bottom five as being facilitated by the common alignment between both parties. It's also important to understand some of the regulations that have been put forth by CMS and other regulatory bodies about data transparency and interoperability and information blocking regulation timelines. So let's focus on 2021. The hospital transparency rule has already been passed. And this speaks to the fact that hospitals are now expected to post their charges for procedures and admissions on the web, accessible to every consumer. That has already started. 300 shoppable services have already been posted. I will say that is very user-unfriendly information as of now, but the process and the demand for hospital transparency has begun. If we skip the second bucket and go down to CMS interoperability rule, that also is in full force. And what this means, it speaks to the fact that CMS is expecting provider organizations to have digital platforms that create visibility for the consumer. Easy visibility in regards to cost of care delivery, in regards to how efficient a hospital system is, what levels of quality a hospital system or an individual provider can deliver. So these two issues of hospital transparency in regards to cost and also quality are already in play. So it is very important that we understand this. Many of our members are in small practices. Several of our members are employed in academia and in other organizations, irrespective of what your model of employment or entrepreneurship is. These things are important to know because they will impact you if you do not know. The insurer transparency rule will take effect in 2022, and that is going to dovetail with the hospital transparency rule. So just a couple of words about healthcare expenditures. Now, all of us know this, but I want to reiterate that healthcare spending in the United States continues to rise exponentially. If you look at global expenditures on healthcare, it's almost 9 billion across the world. But if you look at North America, the United States, as of 2020, just a few weeks ago, eclipsed 4 billion expenditure in healthcare. If you compare that to the gray bar below the US, North America, which is the average spend in other countries within the OECD, Organization for Economic Cooperation and Development, it's about 3.3 billion. So there's a significant difference, and this is nothing new to any of us. But what is important is that the rise of healthcare expenditure as a percentage of GDP has continued over the past 20 years, and it is approaching 20%. Now, with this inordinate spend, if you look at this slide, at the bottom of the slide, you will see the life expectancy of the United States compared to other countries within the OECD. There are about 37, 38 countries in the OECD, and these countries represent companies that have come together to impact global trade and influence. There is not a single African country in the OECD. They control about 45 to 50% of global GDP. The top 14 or so OECD countries are listed here. Of the top 14, the most industrialized and most wealthy countries in the world, the life expectancy in the United States is the least. Yet still, the expenditure on healthcare is the most. And if we look further at other societal metrics of health, such as healthcare access, quality of care, infant mortality, and as depicted here, life expectancy, the United States consistently is in the last position. So this is a paradox that is not new, but what is what is the conundrum about it is that the healthcare industry in the United States has not been able yet to alter this trajectory. So why is that? Why have providers failed to adapt? These are my theories. We have an issue of embracing the incumbent culture of fee-for-service. We have a situation where there is poor accountability for performance within individual businesses and within healthcare systems. The provider enterprises, by provider I mean physicians and hospital systems, have fundamentally developed significant roadblocks to change. There's been a delay, indeed a failure, to accept the imperative of change. And fundamentally, there's been a failure to embrace a culture of data that will enable accountability and transparency in performance. Secondly, the process of incumbents is hard to change. And why is that? That is because the large players, the large stakeholders in the value chain, hospital systems, insurance companies, medical device companies, pharmaceutical companies, the big players in the value chain. And I will say that in this big value chain, physicians and dentists, those closest to the patient at the bedside, feature financially and economically the least. So there's a significant resistance to change because the big players are profiting handsomely from that. Now, from a physician perspective and a hospital system perspective, we have failed to develop standardization that eliminates variation in clinical care and behavior. The concept of value-based care, value-based performance, is more theoretical than practicalized. And the approaches within the industry to value-based care have been very reactive and non-cooperative. Of course, we have technological problems in that our information systems are fragmented, and there is lack of seamless connectivity between business units within hospitals that are within the same system. We must remember that it is the Affordable Care Act that required hospitals to all get electronic medical records at risk of financial penalties. The reason why we are all connected by EMRs now is because there were decisions imposed outside the industry that have made us develop connectivity, but still yet that connectivity is very suboptimal. So there's something that I have defined as a provider predicament. And that speaks to the fact that providers, again, physicians and health systems have failed to confront the growing challenges of the industry by way of cost of care delivery and by way of transparency in performance. By performance, I'm talking about quality and consumer satisfaction. And this has been coined by me as the value vacuum. Now, this value vacuum can be defined, value is defined as outcomes in relationship to cost. If you go to a car dealer, you know exactly what you're buying with the money that you're putting on the table. Within the healthcare industry, it is very hard to codify value. There's a value vacuum. This has resulted in a number of things. Customers are now demanding better. They have expectations. And therefore, because of the inordinate expenditure that is being borne by payers, payers are now shifting financial risk. They're shifting risk to doctors and to consumers and to health systems. There is now convergence across the industry. Traditionally, hospitals have bought physician practices. Dental practices have been conglomerated into large entities. Private equity businesses are buying large portfolios of dental practices, surgical centers. So there's been convergence in the industry. But what is even more telling is that non-traditional players, non-healthcare companies, are seeing the dysfunction in the industry, but more so they are seeing the financial opportunity if they can get into the industry and make it more efficient. So number 3 states that the future of us as traditional providers needs significant introspection. Those who adapt to changing environments, industry agnostic, and healthcare is certainly one, those who adapt will survive. There's several mega trends that are swirling around. There's several headwinds and several tailwinds. However, those who feel that they will survive with their heads in the sand like an ostrich, they will be facing obsolescence, and they will be outcompeted, and they will become irrelevant. Who's responded to this value vacuum? Well, the players in general, the stakeholders have responded. But the main response has come from the insurance industry. And as I mentioned earlier, there's been risk shifting to providers in a number of initiatives and programs. As you see, value-based purchasing, bundled payments, pay for performance. And risk has also shifted to the consumer, as I mentioned, high deductible plans, increasing costs of drugs, and several others. This has been the payer response to the value vacuum. Now, I'd like you to take a look at these 3 to 4 next slides closely. There has been gradual consolidation in the payer industry. If you look at there are 2 panels here. There's one on the left and a larger one on the right. If you look at the left panel, there are 1, 2, 3, 4, 5, 6, 7 bubbles. And they're of different sizes. And the sizes represent the revenue generation of these companies as of 2017. United Health Group, the bottom right, the large dark blue bubble, $220 billion in revenue. Humana, top left, $37 billion in revenue. Again, there are 7. If you shift to the right, you're now seeing a consolidation of these organizations. CVS Health is one of them. It's not a payer, but it is in here. Aetna and CVS now merge. And you see United Healthcare still has a large bubble. But you see that the bubble of Aetna and CVS is now getting large. And if you go to the extreme right, you see that the only single entities that are standalones in this landscape is Humana, 37 billion, and still United Healthcare, the big gorilla, is 217 billion. So this consolidation has begun and is continuing. This has also happened within the healthcare system industry, as you well know. But just to give you an example, Dignity Health and Catholic Health initiatives have formed Common Spirit Health, about 30 billion total revenue prior to their merger. They were each about 15 billion, almost 160,000 employees. The bottom, Providence, St. Joseph's, and Ascension did not happen. But I do know, I do have information that these hospital systems are all looking to see how they can merge. Why are they doing this? So we've seen the payers have consolidated first, and now we're seeing consolidation in the hospital industry. This is resulting in a vicious cycle where one stakeholder group consolidates, and then the second stakeholder group consolidates. Why are they doing this? One would think, as in big businesses normally do, you acquire to provide better value to the consumer. But in reality, consolidation in our industry is essentially a short-term agenda to control power, to preserve margins, and to maintain the status quo for the incumbents within the industry. With every single potential merger, there is the promise to increase value to patients, consumers. This has not happened. This value vacuum persists today. So I told you to pay attention to this, the early iteration of this slide. So we've seen a gradual evolution of the first two panels. If you look at the third panel here, now you have an introduction of non-traditional healthcare entities. Amazon, JP Morgan, Berkshire Hathaway. You've heard about these people. You go to the extreme right. There really now are three big corporate stakeholder groups that are going to impact the future of healthcare in the industry. And look at the size of the bubbles. Look at Amazon, look at Berkshire Hathaway, look at JP Morgan, more than $1 trillion potential. United Healthcare, which was the biggest in the beginning, the extreme left, 221 billion, still generating a fair amount of 217 billion as of about a year ago. But just wait and see how Amazon, Berkshire Hathaway, and JP Morgan is going to impact the industry. You probably heard that Amazon now is into telehealth. So this convergence and consolidation is resulting in a very deliberate, innocuous shift in the power of the traditional stakeholders. Now, the power of physicians is diminishing. Traditionally, physicians have had significant power. Even within the physician enterprise, different specialties have had significant power. In my professional career, when I began practicing cardiology, cardiac surgeons had significant economic power and influence in hospital systems. With innovation in technological devices, that power of cardiac surgeons diminished gradually and then very rapidly. And cardiologists developed significant economic potential and administrative influence. That is changing. Physician power is going down. The power of medical devices, life sciences is also going down. And see where the power is being leveraged. Payers continue to be important because they decide who gets compensated and at what level. The biggest shift is within the consumer base. The most important stakeholder in the healthcare value chain is the consumer. In fact, in any business, strategies for execution revolve around the needs of the consumer. We have an anomaly in our industry in that strategies for execution do not enable or drive consumer value. But the consumer base is now demanding that, and patients and consumers are going to be the most powerful entities in their decision-making in regards to who they go to, what type of services they get, and how they want to get services. And policymakers as well, since they control the regulation, are also going to be important. Just a quick mention about the megatrends. There's several, but these are what we consider to be the top 10. Market consolidation, we've talked about that. Value-based care, we've spoken about that. You all are very familiar with physician burnout. The impact of consumerism, I mentioned that. The demographic changes are important to know because especially those of you in primary care know that there's an aging population occurring across the world and certainly in the United States. And older patients are coming to physician offices with multiple comorbidities. Managing them is challenging. The cost of care managing them is very difficult. The importance of data analytics needs to be critically understood. IT and innovation, health equity, cybersecurity is even more important now than ever before, telemedicine and digital health. So I've highlighted just three that I want to speak a little bit about. So let's talk about physician burnout, which is the ignored public health crisis of our time. You all live within this world. I think that every physician that is practicing medicine has some degree of burnout, except if you're practicing concierge medicine, where you really control your pace of work and you are not beholden to compensation from regulators. But the drivers of physician burnout are as listed. The workload continues to increase, being asked to do more and being paid less. One of the symptoms of burnout is there's a declining understanding of the meaning to do this work. Problems with work-life balance, inefficiency due to undue clerical burden with user-unfriendly EMRs, and loss of flexibility and control over work. Decision-making is completely out of one's hands. These are the main drivers of physician burnout, and several of you, if you're honest with yourselves, are probably manifesting some or significant degrees of physician burnout. Recent data suggests that about almost 50% of US physicians experience one or several symptoms of physician burnout. What is the impact of physician burnout? There's a tripod here. There's an economic impact, there's a societal impact, and unfortunately, there's a significant personal impact. From a macro perspective, burnout is costing the industry almost $5 billion a year. It's almost $8,000 per doctor. It results in suboptimal performance at work, and it results in workforce turnover. We talk about physician burnout. There is also nurse burnout. There's nurse practitioner burnout. There's burnout in the dental profession. There's burnout in the allied health profession. So $4.6 billion a year from physicians alone understates the importance of this problem. So it also results in significant medical errors. It's high risk for medical errors, and that impacts outcomes within the industry. Physicians are sometimes seeking the exit ramp. 40% of doctors surveyed recently plan to drop out of patient care within 3 years. And physicians as young as in their 40s switch professions. Pharma, managed care, health insurance, utilization review, etc. Some physicians seek a second degree, MBA, MHA, end up in management consulting, finance, venture capital, and none of this is bad for as long as one is doing this with a deliberate strategy to do so, not seeking to get out of the problem and trying to just land somewhere else. The second mega trend that should not be a mega trend, because this speaks to healthcare disparities. We've been talking about healthcare disparities within the health industry for more than 100 years. There's a book that I'm reading now. I thought it was on my desk, but it's not. It's called, I forget the medical apartheid. And it talks about the history of medical experimentation since colonial times, since slavery till now. So this issue about health disparities, if you can see this book, it's called Medical Apartheid by Harriet Washington. It's a very excellent read. The dark history of medical experimentation on Black Americans from colonial times to the present. It's fascinating. This goes back to slavery. So this issue of health equity and health disparities being a mega trend is a misnomer. because this has been here since the existence of the medical industry in the United States. So health equity is actually an aspirational desire, because to be honest with you, I am yet to see any human society that has achieved societal equity. So the aspiration for health equity is just that. It's aspirational. And it does speak to the principle underlying a commitment to reduce and eliminate health disparities. Very complex ecosystem to deal with. But this is now spoken to be as a mega trend. The good news is that the Biden administration has put this as a priority agenda. And for the first time, as far as I'm aware, this conversation is going to be managed in a very organized manner, the highest levels of our government. COVID-19 has exposed what we all know. This has been a shock and a surprise to mainstream America. But this is something we've all known. Health disparities have existed in all of our professional practices, from a consumer perspective, as well as from a provider perspective. But suffice to say that COVID-19 has demonstrated some stark, illogical observations, that if African Americans represent just over 12% of the American population, but then account for twice the number of deaths in the US from COVID, on the one hand, and if you look at the bottom of the slide, if Latinos and African Americans represent about 30% of the American population, but they have resulted in almost 60% of the hospitalizations, something is fundamentally very, very wrong. And the world has now seen this in real time with the unfolding of this COVID pandemic. And there is now a convergence of moral justice, societal will, business imperatives, challenging the health industry, and challenging society in the United States to fix this problem. The third and final megatrend I'd like to talk about is digital. And what is digital? I mean, suffice to say that digital is indeed the defining megatrend of our time, not just in the health industry, but in the world. And it speaks to technology, technological platforms that allow immediacy and transparency, real-time visibility and access to information wherever you are, whenever you want it, with the flip of a switch, with a click on a phone or on a laptop. Digital platforms are dramatically transforming business and industry. It allows consumers to interact with people, with organizations, with different groups. I just got introduced to some social media platform called Clubhouse. Many of you may have heard about it. If you haven't, you should check it out. It's very fascinating. People all over the world are coming together around common topics, and health equity is one. All kinds of topics in the world are coming and having chat rooms, real time, 24 hours a day. It can be overbearing. It allows a radically different approach to care. When a physician says, I do things this way because that's the way I've practiced and I'm the doctor, those days are gone, because ultimately your performance is going to be chronicled and it's no longer an opinion of an established, respectful, influential doctor. When you are measured on scorecards and dashboards, you'll be forced to adapt if you are outside the bell curve, if you're an outlier. Vast quantities of data are now accessible to everybody. Data that hitherto was alien and was completely opaque. And as I mentioned earlier, people and other players businesses and other players that have used data to understand consumer behavior, like the Amazons, like the Walgreens, like the Sam's Clubs, are all sniffing around. There's more information about consumers in the health industry, in pharmaceutical chains, more information about their habits, their compliance to drugs, than we have within our own health systems and in our EMRs. If you click, Stanley, a central digital health platform is now connected in a, one more click, in a manner where every individual, every business, an employer, a consumer, a patient, clinicians, hospitals, SNFs, nutrition services, transportation, now have access to this ecosystem through connectivity. So digital transformation is no longer a buzzword within the industry. Forward-thinking industries, forward-thinking health systems are hiring chief digital and transformation officers that are sitting in the executive suite reporting to the CEO, understanding how they can position their healthcare products to be one that is transparently better than the competitor, not based on brand and not just based on marketing, but based on performance that is going to enable a physician to want to be employed by that organization, is going to enable a consumer to want to be treated within that organization, is going to enable family members to recommend that their family members go to that organization. And the issue of telehealth. Now, we all know that there has been an explosion of telehealth. Telehealth is clearly a mega trend. Fareed Zakaria published a book last year. I think the title was 10 Lessons in a Post-Pandemic World. One of them was telehealth. And he stated something I thought was very apropos. He said that there are decades that nothing happens. Talking about telehealth has been around for decades. So there are decades that nothing happens. And then there are weeks that decades happen. What does that mean? When COVID hit, within a matter of 6 weeks across the United States and across the world, telemedicine platforms began to flourish. Now, why is that? Now, the technology existed. The human factor simply shifted because nobody could go to the doctor. People were afraid to go to the hospital. So the point here is that as of now, we saw more than 1 billion telehealth visits in 2020. Teladoc, you're all familiar with Teladoc, I believe is worth its valuation of about 37 billion. Its valuation has tripled in 2020. Telehealth is going nowhere. Within Anpa, we are talking about using telehealth to reach our people in Nigeria. But I think it is very telling that innovation here has happened because of an external pandemic and has now forced the regulators to provide reasonable compensation for people that use telemedicine. There's a lot of work to be done on telemedicine, but the potential of telehealth is, as of now, still in its infancy. I want to close very quickly. I think I've taken a lot of time here about my personal journey, and Enya certainly wanted me to mention this as a cardiologist. I will say that it has been an interesting journey. I came to Charlotte, North Carolina in 1989. And my journey has exposed me from the micro perspectives of starting a solo practice. And I've been privileged to now understand the macro perspectives of the industry. I got the best of education in Nigeria that one could ask for. There's several ways to get good education, but I certainly got very good education in Nigeria at King's College, Lagos, and University of Ibadan Medical School. And as I mentioned, I came to Charlotte in 1989. I was not hired by any practice, so I had to open my own practice. And some of you will remember Yemi Johnson. I opened my practice in 1989, and by 1994, there were 4 of us African-American physicians. Yemi Johnson was one. David Dowdy was another one. Lydia Sutton. We're the first 4-physician African-American practice in North Carolina. We were very busy, really very busy, to a point that in 1994, we merged with one of the practices in Charlotte, an 8-physician, all-male Caucasian group, and we formed the first interracial single specialty practice in North Carolina. I eventually became the president of that practice. We began as 12. When I left the presidency, we were 38 cardiologists, and we had the unique privilege of hiring the first female cardiologist, Caucasian. And just before I left clinical medicine, we had the first African-American cardiologist in Charlotte. I also had the privilege of being a founding member of Anpa several years ago, when 25 of us gathered together in Anaheim, California, with nothing but a dream. I became past treasurer and past president, and very privileged to have been part of the journey to what we see today to be where Anpa holds the very enviable position of being the most influential diasporan medical organization in the United States. I was a senior vice president of Heart and Vascular Services at my previous organization, a $6 billion company, 14 hospitals across 4 states. I was on the board of trustees for that organization for a while. I had an epiphany and went to MBA school in my mid-50s. When I look back now, I wonder who does that, who goes back to MBA school. And to be honest with you, in my work at my previous organization, when I got exposed to executive coaching, I found the answer, because I was asked by several people, why did you have to do it? Why do you think you had to do it? The truth of the matter is that it demonstrated some fundamental insecurities in myself that made me think I had to overcompensate. So emotional intelligence is something I speak to in a minute, but I have no regrets about doing it, because it certainly has improved my perspectives on life and my abilities to maneuver. I left clinical medicine fundamentally because I went to MBA school and I had a shift in focus. I had different interests. I didn't leave because of burnout. I will say that I actually left, if I say so myself, at the top of my game. But I just developed different interests. I was more interested in being impactful in the industry and being engaged in conversations within industry leaders that could potentially positively impact the industry. And that's what I'm trying to do now as Chief Medical Officer at EY, Ernst & Young. The work that I do involves engaging in thought leaders within insurance companies, CEOs of health systems, biopharma, and so on. Now, I've learned a lot, and it's impossible not to learn a lot as a practicing physician. We all will agree that it is a noble profession. Those that don't like medicine tend not to survive for too long. Those that love it understand that just getting out of bed in the morning and putting on your clothes, your shirt, your tie, your dress, getting into your car and going to work in your office or in the hospital, every single day you do that, you're bringing value to humanity. You're making people feel better. You're making people live longer. By so doing, you're bringing long-term value to society. All professions are important. The financial services, legal profession, law enforcement. But I will say that I do not know that there is another profession whereby every single day you get up and go to work, inevitably, you're making somebody feel better, you're making somebody live longer. So there's nothing to sniff at about medicine. One must be proud of our roles as physicians, but we must be humble that we're able to do this for our patients. With all that being said, the very nature of our profession creates narrow guardrails of emotional intelligence. We think very linearly. Go back one slide, Stanley. We think very linearly because we have been embedded within a life for over 20 years at a minimum, where you are surrounded by people that think like you, doctors and nurses. And there's a whole world outside the health industry that we are completely oblivious to. But fundamentally, we must stay focused as physicians and dentists and nurses and nurse practitioners. Your core competency must define you. You must be regarded as a professional first and a competent one at that. And by so doing, you brand yourself and enables you to be known for one thing, and that is delivering value to patients one at a time. So what do I advise? I think that medicine can be restrictive, and if you are of the bent, you should diversify your professional opportunities, invest in meaningful networking outside the traditional Nigerian comfort zones. It's not a bad idea to consider another degree. You will hear about financial strategies. Medicine alone won't make you wealthy, but you can become wealthy as a physician or a dentist. But it takes understanding the basics of financial investing. It's a long game. It takes discipline and patience. I'll close by saying on the next slide, a couple of comments. The eagle leadership philosophy. Eagles fly alone and at high altitudes. They don't fly with sparrows or other small birds. They swoop down periodically. The red font is my interpretation. Stay away from narrow-minded people, sparrows and ravens. They bring you down. Eagles fly with eagles. In other words, keep good company. Do not be elitist, but have friends in high and low places. Eagles have accurate vision. The eagle will not move his focus from the prey until he grabs it. Have a vision, remain focused. No matter the obstacles, you will succeed. Eagles do not eat dead things. They focus on fresh prey. Do not rely on past success. Obviously, we eat dead things, but the ethos here is keep looking for new frontiers to conquer. Leave your past where it belongs and be prepared to reinvent yourself if you need to. Face your challenges, knowing these will make you stronger and better than you were. Achievers face challenges and relish them and use them profitably. Eagles prepare for training. They remove feathers and soft grass in the nest so that their young get uncomfortable in preparation for flying. So be willing to get uncomfortable. Leave your comfort zone because oftentimes there's no growth there. The last slide speaks to when choosing a partner, the female eagle drops a twig from varying heights. Once its male suitor has mastered the art of catching the twig and showing commitment, by returning it to the female, only then will she allow him to mate with her. But my take on that is whether in private life or in business, one should test the commitment of people intended for partnership. It's important to have a kitchen cabinet. Keep an inner circle. Trusted people. Bounce things off them. Accept their criticism. It expands your influence, your decision-making, and your emotional intelligence. So the eagle never gives up. So to be a leader, be an eagle and never give up. And thank you very much for your attention.
Thank you. Thank you very much, Dr. Aluko. Wow.
Wow.
See,
Wow. What Enyi, I just have to say something. This was, I'm speechless, Dr. Aluko. This should be, and the president is here, he's smiling. This should really be delivered in a different location if it wasn't for this pandemic. This is something, the advice here is deep. Chris,
This
I
is a
don't
keynote speech.
I mean, Chris?
Thank you very much.
I said this is a keynote speech. This should be a keynote speech, Dr. Aluko. We are bringing you back somewhere. This has to be repeated somewhere, please.
Yes, yes.
I'm at your service.
Very, very, the advice here, I guess we'll have questions at the end. It is well received. It took a long time, but it's worth the time investment. Enyi, I know you have a comment. We are running short on time, but we will cover all the topics. Would you mind introducing our next speaker, the most wanted man in America by IRS?
thank you very much. And I'll be remiss in not adding my own appreciation for Dr. Aluko's presentation. Now, we've basically talked about the business of medicine. That's what Dr. Aluko's presentation was about. We're going to pivot into the practice of medicine, and we're going to approach it in the context of what's in it for me. What's in it for you, the medical practitioner? I have experts who are going to give very brief ideas, and then we're going to open it up to questions. First will be the most wanted taxman in America by the IRS. Some of you may have listened to him last month, Mr. Hubert McIntosh, who is a CPA and a certified tax master. Then we're going to have a retirement plan specialist, Mr. Mark DiTondo, and an estate planning attorney, Mr. Owe Bele. After that, we'll open it up for questions, and you can ask any questions of anybody, including Dr. Aluko. Hubert, over to you.
Wow, thank you, Enyi. Thank you, Anpa. Thank you, Mr. President. Thank you for co-sponsors. And Dr. Yele, I don't know if you were watching my face, but I don't know how to follow after you, sir. What you have delivered, I see for the few of us here, I consider this a privilege. This is the kind of presentation that should be on a platform where millions of people are listening, and we were privileged for this. Dr. Yele, thank you. Thank you. I don't know how to follow, but I'm going to try, because you have established some things. It's almost like we prepared for this. So you have established some things to make what I say easy, because I'm just going to pivot from certain things that you have said. Can we move to the next slide? The next one, I think the other one, I think it's upside. This is the one I wanted first. So, wow, you all have listened to Dr. Aluko, and he pointed out some power stuff. So what I'm gonna look at macro and micro. So Doctor spoke about the macroeconomics. You're gonna look at in the industry. You're gonna look at the medical industry nationwide, worldwide. That's the macro part of it. He also mentioned the micro part of it. How are these trends gonna impact you individually? The individual physician, when you look at this, how will it impact you? And you have some challenges, but the beautiful thing how Dr. Luca ended, you have challenges, but if you operate like an eagle, you're gonna overcome. You're gonna overcome where you can look at these challenges and identify individual opportunities. So let's talk about the micro part now. You, the individual physician and your family with your current income, your current taxes, and we're gonna talk about a different macro, not the industry, not the world, but your macro, because a lot of times as individuals, when we look at our tax situation, we're looking at it at the micro level, where the micro level is, here it is, we're 2021, you're gonna prepare, you're gonna file your taxes for 2020. That's the micro level. But what you have to look at now, the macro part of it is, as you define, and Dr. Oluko said it, lifespan in America, 79. Some of us will reach there. Some of us will go longer. But here's one thing none of us knows. None of us knows our number. None of us. So it's easy to say the average is 79. But what if yours is 100? But you only planned for 79. That makes a horrible future. And I dare to say, inarguably, some people may argue, but I think it's inarguable. One of the number one impediment to your current and your future wealth are taxes. It's inarguable, our taxes, because what is happening, especially as we talk about the pandemic, what happened? So we hear about stimulus package and we hear about this thing, but what is happening? Our country that we are in right now, if you look at the US debtclock.org, it will give you an idea. We are $27 trillion in debt. And every year we are operating at a deficit of $3 trillion. So do the math, 27 in debt, 3 million deficit per year. As an industry, the global economy that we are in now, we are not so exclusive. Dr. Oluko, you shocked me. When I knew that there were challenges. When I saw that we as a country were number 14 on the list, the bottom of the list. So what does that mean? As a country, we are not being very competitive. So what will happen? For the government to deliver or even attempt, they have no choice. I don't care who's the administration. They have no choice but to increase taxes. They have no choice. No choice but to increase taxes. So this is where it comes personal now, where each of you have to stop. You know tax is going to increase, and you introduce, doctor, your income, even though some of it may have decreased, your income is not common. You still have the privilege of earning uncommon income. But here's what I see. A lot of you're earning uncommon income, but you're using common strategies. Do you see the misalignment there now? A doctor thinking of a 401k. Let's be real now. It's not a product, it's just education we're talking about. You earning 200,000, whatever the number, 200, 300,000. 401k allows you to deduct 19,500 19,500. First of all, it's not enough deduction, and 19,500 cannot accumulate for you to have a successful retirement if and when you choose. So that's, you know, so in the limit of time. So what I'm telling you, as tax masters, what do we do? What do we do on a micro level? We help you. As financial doctors, we don't save lives and that's why we model. We love the medical profession. And Dr. Oluka said it best. You have the creditable position of where every doctor, every single doctor gets up every morning, has the opportunity and knowing that he or she is gonna make a difference that day. Doctors, that's how I look at you. Every single one of you, you are making a difference. But the but now part, now where you have to stop and look, it says you're doing that, but you have to stop and ask yourself, are you evaluating your situation? Because you're a noble profession, but at the end of the day, you also have to take care of number one, and if you don't, taxes gonna impede you. So what we help you with, Doc, and it's just gonna be quick, I'm just gonna go. We, just the same way a patient comes to use us, we diagnose your situation. And let me clear up something, because I've gotten this objection sometimes, whereas tax masters and tax professionals, someone is careful and they says, well, but I have a CPA. Yes, I'm glad you say that. But let's ask, and Dr. Oluka, I so appreciate Dr. Oluka, who's a cardiologist by trade and profession, and guess what? Dr. Oluka does not change the person who have a general practitioner. There's nothing wrong. You have a general practitioner, but there are times you need to see the expert. You need an expert opinion. The cardiologist does not change someone from having a primary care physician, whether it's a GP, internal medicine. The cardiologist doesn't change, but it gives a perspective of the heart. So what we're doing, helping you to diagnose your tax situation. So what we do, we diagnose it, because as it says, it's not a one fit all. Each situation is different, but we diagnose it because there could be many reasons why you are paying. You're paying unnecessary and unknowing taxes. And the diagnosis will help with that. Okay, with that, and we take further, and then we make a prescription similar to what you do. What does the prescription entail? The prescription is going to be determined from the diagnosis. Because you as a doctor, you cannot provide a prescription to someone if you did not see them or diagnose them, because that would be malpractice. That would be malpractice. You cannot make a prescription before you do a diagnosis. And after you do a prescription, and I love how the doctor framed it, where you look at CVSL, when you get a prescription, then what do? Some prescription, it may be oral medication, it may be liquid medication, and some prescription may need a treatment plan. May need a treatment plan. It may be something that's gonna take a period of time. So I just want to bring this to you, because and not take too much of your time, but this is what we talk about when it comes to financial planning, tax planning, whereas part of the treatment plan now is where, as you look at your micro retirement, then you need specialists there. And with that, I am proud to announce my friend Mark, who's going to share some stuff with you in terms of implementation of a treatment plan. So Mark, thank you. Over to you.
Thank you, Hubert. First, let me just start off by saying that presentation by Dr. Oluka was truly outstanding. I look back, I started my career 32 years ago. And my father before me had a 38-year career in the financial service businesses. So you talk about burnout and you talk about getting up every day, putting on your shirt and tie, and doing your job. And one of the things that my father told me very early on in my career, maybe like the first week, is every day you get up and you help somebody. And I can tell you over my 32-year span, just like many of the doctors on this call, you prescribe things, you get people healthy. I put people through school. I provided the life insurance check that provided people to stay in their social well-being, because when people go to the funeral and they leave, we're the one that brings the life insurance check. And I've migrated my practice to doing only retirement planning for high net worth individuals, because those people, like so many people have said before me, Hubert, Dr. Luco, qualified plans is where you can keep your income in retirement. And most people, like Hubert said, think about a 401k. The retirement planning world is so far beyond the 401k, it's mind-blowing. When I sit and I talk to high net worth individuals, doctors, lawyers, small business owners, and I ask them a simple question: what's the most you can put away into a retirement plan? Like Hubert said, they say 19,500, they say 13,000. And I'm here to profess that a person age 60 owning their own business with no employees can put away as much as $325,000 a year into a retirement plan. Yet such a small percentage of people even know about this. And so one, I just want to thank you for the opportunity to speak today. It's such a privilege and an honor to speak to such an astute group of people. And I'm just going to go over a couple of quick slides to demonstrate some of the work that I can do, and that I work with through NE and his group to help you with these plans if necessary and desired. So can we just go to the next slide? So here's the array of different types of qualified plans. We have SEPs, simples, profit sharing 401ks. Most people are aware of that. But the work that I do is on the defined benefit side. Traditional defined benefit plans, most commonly today, cash balance plans, and 412Es for sole practitioners, single run family businesses, and partnerships. These are all available to you. No, go back one. Next one, please, yes. And look at the gamut. As you had so eloquently said, we talk about the $19,500 that we can put away. But if we look at this next slide, Stanley, when we look at a simple, it's $25,000. We can go all the way over to the right-hand side of the column, and that's over $300,000 in a 412 plan. So this is a business owner, age 50, making the maximum $285,000. And look at the different array of products that are available. Most people focus on the blue side, the simples, the SEP, the profit sharing plans, the 401k. They never talk, the financial advisor or their CPA, never talk about what they can do on the right-hand side. And when I tell you that the right-hand side complements the left-hand side, okay, you can add a traditional defined benefit plan to a 401k. You can add a cash balance plan to a 401k. You can add a 412E3 to a 401k. And they're not talking about that today. Here's the good news. 2020 in my world is not over yet. So you can still put in a plan on the right-hand side of this equation for 2020. Time is not over yet. You have to your filing date, because of the Secure Act of 2020, to implement a new plan or an additional plan. What I try to emphasize to most small business owners is that we're not replacing what you have on the left-hand side of the column. All we're trying to do is complement and make a bigger deduction, a bigger contribution. And on the right-hand side of the column, the money there that goes in is all guaranteed. It's a guaranteed retirement. And at age 62 or 65 or 5 years if you're already 65. Slide, please. I'm just going to go over quickly some plan design considerations. Most people today, when they start off as a sole practitioner, set up a SEP because you can put away $57,000. There's no plan administration fees. Next slide, please, Stanley. I'm sorry. So here's a current SEP. An owner 54 has a spouse 51, 2 employees aged 34 and 43, has a SEP but wanted to vary the contribution. Current SEP contribution is $61,000. So next slide, please. So what happens is most people start off their own practice. Dr. Luco said he had his own practice back when he first came to North Carolina, and he probably started with a SEP because—
Oh boy, that's your ball. Wow. I know.
Please.
So he started with the SEP that he could put away $57,000. But when you add an employee and they're there for a period of time, and the rules are 3 out of the last—
Turn the unmute
Oh
yourself.
my.
Somebody playing golf?
No, it ain't short. Eh? No, he crossed.
Go ahead.
Okay. So when you start adding employees to your practice, if you keep a SEP in place, you have to contribute the same contribution level that you put in for yourself as them, which is 25% up to $57,000. So on our example, the 2 owners can put away $44,000, but because they have to contribute for their 2 employees, they have to put in $17,000 for their employees. Low-hanging fruit, some of the early suggestions that I make to small business owners is switching to what we call in the industry a cross-tested profit sharing plan. You can see that not only does the contribution for the 2 owners go up, but the contributions for their employees goes down significantly. Now, they do have to file an administration fee called a Form 5500, and that's $1,350. But most business owners would like a larger contribution for themselves. Maybe they want to give their employees the same amount, maybe not. But in this example, they're giving $10,000 to themselves, and they're only putting away for their employees in an administration fee, $5,600. So that's a simple idea for those who are currently using a SEP but have employees. The next one.
I think that's your
Okay,
slide.
those are the things that I wanted to cover. But if we could go back to the slide that had the array of different products. The next one down. Next one. This is what's still available to you all today. Profit sharing, defined benefit plans, cash balance, and 412s. I'll turn this back over to Enyi. I just want to say again, thank you for the opportunity and the privilege to speak with you today. If you have any questions, I'm more than happy to entertain them.
Thank you very much.
Thanks. Thank you. I am going to invite Owe, the estate planning guy, to now give his presentation. Thank you.
Thank you very much for having me. Good afternoon to everybody and Happy New Year. And as with everybody, I was blown away by Dr. Luco's presentation. I'll be very brief. And I have presented at Anpa functions and Anpa conferences several times. And the gist or the gravamen of my presentation is summed up in a phrase that everybody seems to chuckle at. My title of my presentation usually is Trouble Not a Blow Whistle. And it's very informal and very, but I think to the point. As Dr. Luco mentioned, we are evolving. You are evolving as a medical practitioner, as a physician, as a doctor, you are evolving as a family person, you're evolving as an entrepreneur, and yes, you're evolving as an immigrant as well. And part of that evolution and part of going to that next step is doing your financial planning, is organizing your affairs, getting your affairs in order. I don't think that we can compare the variety of financial instruments and tax planning that we have at our disposal today to what our forebearers or our parents had in terms of their financial planning in Nigeria. We are living in a very complicated society, and we need equally as complicated tools and resources to navigate ourselves through the society and achieve the goals that we want. And that is where estate planning comes in. It is a collaboration of selecting the right financial instruments, laying out the appropriate tax plan, and incorporating it in a plan, an estate plan that meets your goals, that enables you transfer your asset from one generation to another, all the while minimizing your tax liability and creating asset protection for yourself and your family. That's the purpose. And it is, as Dr. Aluko stated earlier, we are a unique bunch of people because you're physicians, you are immigrants, and to some extent, for some of you, you're entrepreneurs as well. And with that, creates specific liabilities that's unique to your circumstance. The average person is not exposed to litigation or likely to be sued like the average American physician. We live in a litigious society, and there is going to be a time where you'll be served with a demand letter, where you'll be served with a claim from a patient that didn't make it. And the initial response is, well, that's what insurance is for. And that's true. That is what insurance is for. But there will be circumstances where that $1 million policy just isn't enough. And if you haven't done any planning, your personal assets now become into play. They would want a financial disclosure to determine what your assets are before any case is settled. So it is imperative that we do the planning for a number of reasons: to lower your tax liability through tax planning, to protect your assets from litigation, to create a legacy plan to transfer those assets from one generation to another, and to create also a plan that reinforces the values you have and that you're transferring from your generation to your children's generation. And those are the things that we look to accomplish through a comprehensive estate plan. If you do not, and now there are estate plans and there are estate plans. Everybody can have a will that says all my assets goes to my eldest daughter or to my eldest son, and that's the end of it. But I suspect that with each one of you, your life story and your objectives are a bit more complicated than that. You have to worry about the house, you have to worry about the retirement accounts, and the laws are constantly changing. And so to think that you have a one-size-fits-all, a cookie-cutter approach, just get a will and that resolves the problem is not good enough, to put it bluntly. You are an entrepreneur, you are a physician, you are a serious person and you take your profession serious. It is imperative that you surround yourself with a team of people, a tax advisor, a retirement planner, a financial advisor, and an estate planning attorney that can assist you in navigating not only your business plans, but transitioning to retirement and transitioning for the wealth for your next generation. It is one thing as an immigrant to be success in America and make your money, and it's another thing to keep that money and transfer it to your loved ones. And that's what good estate planning does. As I stated earlier, I'll be very brief. There's a number of items that affect an entrepreneur. As Herbert said, we all have to pay taxes, and the portion of the proportion of taxes that you pay and your tax liability can determine your ability to be successful or not successful as an entrepreneur. In addition, there is liability from the society in general, liability from car accidents, liability for medical malpractice, and there's also internal liability for marriages and family relationships that go wrong. What's your exposure? How do you guide against that? How do you protect yourself against that? So these are things that every entrepreneur, every physician, and I dare say every immigrant under these circumstances has to be aware of and has to plan for. And one way to do all that, to encapsulate all those various things, is to have a team, as we've described here, that includes an estate planning attorney that can navigate you through these waters. Thank you, and I'll take your questions, if any.
Thank you.
Thank you very much, Owe. I noticed you didn't want to use your slide. We appreciate you speeding through the presentation. I'm going to, however, show your slides just because this is being recorded for future use and evidence. You were here.
Just go back one quick slide and then we'll go into questions real quickly. Go back one more. Okay. The only reason this slide is here is to remind you of these pillars and the power of these pillars and the expertise that's built around them. Go on to the next one. And this one here basically gives you some outline of risks and rewards or returns associated with different assets and asset classes and things like that. These are all things that we're going to talk about in future webinars. Go on to the next slide because we're going to now go to what this is about today. A lot of us have raved about Dr. Aluko's presentation. Thank you again. I am going to open it up for questions. And yes, this has taken longer than we envisioned, but you can understand why. We hope we can answer most, if not all, of your questions today. So Stanley, I'm going to hand it over to you guys to begin the process.
All right, Susan and I are going to be asking the questions. So if you have any questions, feel free to either type it in the chat. You can send, if you're shy, you can send it privately to Susan or myself. And if you're bold enough to speak for yourself, you can unmute yourself. So there's so many ways to ask questions, and it's up to you. One very common question that's always asked is, these seminars seem to benefit people who are self-employed or have small businesses. How about the employed physicians who are participating in the employer's 401k? What options do they have to save more than that 19,500 that's allowed in the traditional 401k? Anyone?
Hubert, I'm going to ask you to answer that question as briefly as possible.
Yes, great question, great question. That's why I introduced micro versus macro. Saving taxes in a particular year is a micro view, but you also have a macro view. So here are the challenge for the W-2 employees, because the W-2 employees, the government, they'll say, well, okay, you can use a 401k, but as a physician, that doesn't help you. That's a 401k is a qualified plan, as Mark spoke about, but you also have non-qualified plans, whereas you're not gonna get an immediate tax deduction, so you don't qualify, you don't solve the micro part. But in these non-qualified plans, your future retirement income, you can receive it tax-free for the rest of your life. If you start at 65, 60, whatever it is, you can receive it for tax-free for the rest of your life. So you would harvest your tax savings in the future and not necessarily currently. Business owners can have it currently and in the future. W-2 employees can have the tax savings in the future.
Thank you very much, Hubert. Next question.
What is the difference between a cash balance plan and a 412E plan?
Mark DeTondo.
Yes, thank you very much. The major difference between a 412E3 and a cash balance plan is a 412 typically does not involve any employees because it's a fully insured plan, meaning that it's a guaranteed interest rate and it's a guaranteed return on your money at a specified age, whether it's 5 years, 62 or 65. A cash balance plan can involve employees, but there's different layers of employees and different contribution layers and different contribution amounts that can be provided for employees.
Thank you.
Thank you.
Next question, please.
I have a question. This question is to Dr. Aluko, and I first wanted to preface my question by saying I wholeheartedly appreciate your presentation, and with all sincerity, in all of my days of residency and fellowship training, I have yet to have a faculty member or advisor give me that kind of breakdown of the healthcare landscape and give me advice for my career planning that was so on point. So I'd like to thank you again. So I find myself now 5 years in practice wanting to start my own private practice. And based off of what you spoke about in your presentation, I mean, it seems like the scales are clearly tipping in favor of these large corporate conglomerates. So my question to you is, if you were in my position this early in your career, looking to start a private practice, would you do so in today's environment with all these equity firms buying up practices and the like? Would you do that? And if so, how would you position yourself as a small solo practitioner for success in today's environment?
Dr.
Thank you very much for that very insightful question. Let me answer it in this manner. When I decided to start private practice, I actually did somewhat of a feasibility study looking at cities in the Southeast USA, looked at 20 cities, looked at certain things about the population, the African-American population, the number of TV household users, access to good schools, access to healthcare facilities, educational facilities. I use that as a matrix to understand the potential of succeeding in a business, not necessarily healthcare, but business in general. I knew I was going to start a private practice. I looked at the competitive landscape as well. I knew there was only one Black cardiologist in Charlotte, and I knew that I had skills that superseded any of the cardiologists in Charlotte at that time, because I was coming straight out of an angioplasty fellowship. So I looked at skill set, looked at geography, climate, social amenities, educational. Now, why am I saying all that? The world has changed significantly since then. If I was going to start a private solo practice today, I would have to have a unique value proposition that separates me from the general. And you can apply that to any geography. If you are starting a primary care practice in Charlotte today, it'll be more challenging. And it'll also be more challenging if you're doing a specialty practice, but not impossible if you have a unique value proposition. So it's more about strategy and decision-making and using that to drive where you start the practice. You will be overwhelmingly successful if you are the only doctor in a small community. But if you want to be in New York City, you can still do it, but you will be dealing with people that want solo practitioners, and there's a market for that. There's some patients that do not want to deal with hospital systems, but there are bigger risks. So you can't go wrong if you want to do it. You have to use strategy to decide where you do it and how you separate yourself from the pack.
Thank you.
Thank you.
Can I make a comment on that, please?
Go ahead, Dr. Emerowa.
I missed Yele's presentation. I'm so sorry for that because everybody's raving about it, but I hope it will be on the video chat because I can't wait to see it. I think one of the things also that I want to comment as somebody who is in the trenches in the private practice world is that there is a gap that's being created that really can be filled by physician entrepreneurs. Because the number of people going into solo practice is a very small minority of physicians today, there is a niche for those who want to go into private practice because a lot of physicians my age are looking to retire. And because they are looking to retire, the value they attach to their practice is minimal compared to when I came out. And it also creates an opportunity for you to aggregate some of these retiring physicians' practices and create a small group practice. Now, the downside of private practice, the quality of life issues. So you have to be sure that within your market, that there are 2 or 3 or 4 other people who can help you cross cover because being a private practitioner means that you're responsible for your patients all the time and you have to make arrangements for that. But those are things that you can consider if you're looking at that opportunity. But there's a big opportunity of primary care physicians retiring, cardiologists retiring, ENT doctors retiring. And unfortunately, their prices are not big enough for the mega corporations to be interested in, and yet there's value in it. Thank you.
Thank you, Dr. Emerowa.
Thank you, Dr. Emerowa. Does anybody else have any other questions? I know it has been a long webinar, but it is worth it. Any other questions? Any, let's see. There's a question, I'm not sure what that is. It's something about hiring a nurse practitioner.
I think that's just input from one of the doctors.
Oh, okay, okay.
I have a question.
Go ahead.
And it's going to be for Dr. Aluko. This is Dr. Gertie Anyawoke. I want to join everyone else in saying what a wonderful, excellent presentation he gave. And it really solidifies a lot of stuff that's happening out there. I am a private practitioner right now. I own my own practice. And so my question for Dr. Aluko is that, given that the medical world has been, for better, for worse, forced into the telemedicine aspect of medicine, whether we like it or not, how would you advise private practitioners like myself in terms of positioning ourselves in this world of telemarketing and telemedicine? Thank you.
Thank you for your question. Telemedicine is here to stay. So we have to be able to pivot, to be agile, and understand the time to adopt new process and technology. If you don't engage in telemedicine, you are at a competitive disadvantage. It's an evolving competency now. And the government is going to be reimbursing more clearly, but it's going to be very clear that telemedicine is not going to apply to certain specialties effectively. So you have to be in the game, and you have to be positioned to be in the game with your technological infrastructure. You have to pay attention to the evolving trends. You cannot be left behind. You will still potentially succeed because there will be some patients that don't want to engage in telemedicine, but to be a significant player with a growth opportunity over time, and to be able to attract future physician partners, you must be part of this digital revolution. So you need to be in the game. Now, that being said, I have a question myself for the financial people. All of us as physicians get bombarded. I probably get maybe 4 requisitions a month from different financial institutions, life insurance, financial planners, the whole, estate planners, the whole competency are seeking to engage physicians because physicians are high net worth individuals. And it gets confusing. Now, earlier in my career, I wish that I had done what I've done now, to adopt a very deliberate approach to investing and developing this type of relationship that our speakers have put together. But the observation and my question here is this: how will you advise the younger mid-career physicians and dentists and other professionals to adjudicate all these requests? Because you guys know that the average doctor probably has insurance policies here with this company, disability policy somewhere else, no will, estate planning, you can't find the papers. How can you advise our organization to be disciplined and deliberate about approaching a wealth management strategy?
Anything, can you take that, Anyi?
Absolutely. Thank you very much, Dr. Aluko. The whole mission of this series is to enable this association's membership to get the benefit of what you just talked about. What the goal is essentially is around educating you on how to aggregate a team. You must have a team of specialists. If you recall, one of the first slides, the first slide we showed on here was the pie that had the estate planning attorney or estate planning, tax planning, insurance planning, income planning, investment planning. These pillars essentially are truly specialized areas. And that's what Dr. Aluko is asking. You need the right team, you need the right experts, you need them working in concert though. They need to be working together because tax planning is not tax preparation and people misunderstand that. Investment planning is not stocks and bonds. You will come to find when you dig deep into investment planning that it's a very wide spectrum. And I think if you recall, there's a spectrum there. When we touch on investment planning and touch on investment alternatives and solutions, you're going to see and understand these better. Insurance planning is a broad area. It's a totally misunderstood asset class. That is our next subject, by the way, next month in February. The title of that presentation is Insurance, the Misunderstood Asset Class. You will be surprised at what insurance can do. People don't have any clue the power and the capacity and how insurance is the most powerful tool from a wealth accumulation standpoint and how the very successful, the ultra affluent are using it. Those are the kinds of things. Surround yourself with expertise. Make sure that they're working in concert. It's a team effort together. All these experts have to come together. You guys are running multidisciplinary practices. You all have specialists. It's the same thing. I can say this, that at Wealth RX for Doctors, it is an aggregation of expertise. It's a team of multidisciplinary specialists that provide all of these things to the client in a coordinated, concerted manner to give you the benefit of that synergy. Look for those relationships. That's what I would suggest you do. And make sure that you have a plan that incorporates all of these aspects. Orway could not say it enough. It is so important, so important that you start with an estate plan. You make sure that you get the asset protection. As a matter of fact, one of the subsequent months, we're going to deal primarily with asset protection. You guys have assets and you've accomplished a lot, and there needs to be a good understanding of asset protection, among other things. Hopefully that's answering the question.
Thank you very much, Anyi.
I want to add something to what Anyi said, if you don't mind.
Okay, after Albert, I'll go to Dr. Aham Onyike.
Okay. Dr. Aluko, your question is great, and I understand it because when you're bombarded with the noise, with wire from wirehouses. So because sometimes you're faced with this question, okay, I can deal with Schwab, I can deal with Fidelity, and I can deal with Edward Jones. There's so much noise, and you're hearing that, and you're hearing that. But one of the key things directly to your question, Dr. Aluko, is the sense that a lot of times the wirehouses, they're telling you about your accumulation. Almost anybody can help you with your accumulation. And you hear always said it so well. It's not what you earn, it's what you keep. So you get this accumulation, like some of you now may even have some IRAs or whatever, you accumulate and you get the monthly, the quarterly statement and you see 1.5 million, you see 2 million, but here's the reality. Here's the reality, your 2 million is not 2 million because it's only measured at the tax rate. What if when you're gonna distribute, your tax rate is 50%? All of a sudden your 2 million has become 1 million. So any investment you're gonna do, always look at the tax consideration. With tax consideration, as I said, all these are emphasis are good. Estate planning, insurance planning, income planning, always look at the tax consideration. And if the person who is speaking with you cannot speak to you, and as Enya says, cannot introduce or interact with the tax, be careful, because it's like you go to Mount Everest, you got to look at, you have one of two choices. What kind of Sherpa are you going to use? Are you going to use a Sherpa that's helping you to get to the top of the summit? So you get to the top of the summit and you're celebrating, but how are you going to get down if you don't have the proper Sherpa? Because the rules for accumulation and decumulation, they're not the same rules. The rules change when you get to the top of the summit, because that is when you got to start dealing with the tax man.
Thank you, Mr. McIntosh. Dr. Ahamo, UK.
Thanks, Stanley. So I definitely want to commend you.
Add to that.
Yeah, you go after that, Lawrence.
Okay, thank you.
Go ahead, Dr. Onyike.
Thanks, Stanley, once again, and thanks to the rest of the team that put this together, the speakers, and Anpa in general. Question is for Dr. Aluko, whose presentation, as everybody else said, and I concur with, was impressive. You know, what really piqued my interest was the idea of anticipating the landscape and knowing where things are going. The digital space speaks for itself, and we all see the changes that rapidly coming down the pipeline. It brings my attention to a comment from Wayne Gretzky, who was the greatest hockey player, arguably, who says that his greatness was from knowing where the puck was going to be, not where the puck is. And with that in mind, in medicine, for me as a surgeon, there's been two things that seem to be artificially shackling us. One is the limitations on certificate of needs, and the other is the malpractice insurance. So I just want to see, Dr. Aluko, if you could just quickly respond, understanding that it's a little bit of a deviation, but considering the presentation on the bird's eye view perspective of the upcoming landscape in medicine, coronavirus has sort of exposed a huge demand for certificates of needs, which will allow many of us as surgeons to be able to take advantage of the cost-saving incentives and still have a superior model of practice that could work if the legislations are deregulated. And then also malpractice and litigation culture. Are there any brief comments on those two areas? Dr. Aluko, thank you.
Yeah, Aham, thanks for your questions. So many states are looking at dismantling CON regulations. And you're speaking through the lens of a physician entrepreneur, in that enables you and other physicians like yourself, procedural specialists in particular, specialists, gastroenterologists, surgeons, and so on, dental professionals as well, to have their own enterprises. For as long as your strategy is to drive value. And again, it's important to be able to document your value, to own your own data that shows that your enterprise is giving value. Now, you imagine if you had a fleet of 10 ambulatory surgical centers across the country, and you develop a portfolio of metrics that are driven by the American College of Surgery. All our parent organizations have quality metrics. But the truth is that our reimbursement through payer organizations is not as granular as it should be when it comes to quality. Quality speaks to hospital infections, mortality, and other things. But if you have ASCs, and if you show Cigna, Blue Cross, Blue Shield, you've embraced digital technology, you're going into ASCs not because you can now divert patients and make more money for yourself. Yes, you will make money for yourself, but by the way, you have a portfolio of metrics that shows Cigna that they should send patients to you. And the metrics I'm talking about are not the usual metrics that Cigna or United Healthcare is publishing. You have innovated your DNA and your culture to be transparent about your cost and your outcomes. So you are doing what Wayne Gretzky has said. You're looking around the corner at things that other people don't see. And if you do drive value to the industry, and I keep on going back to this concept of value, not personal value, but consumer value. The personal value is that you make more money for yourself. Nothing wrong with that. If you match that with consumer value, then you become unstoppable. If you're able to do that, you are more negotiable to lower malpractice costs. But absent of data that you own, you are beholden to the data insurance companies are collecting about you, which ordinarily is not always right, because as you well know, United Healthcare has a profile on you, Cigna has a profile on you, Blue Cross has a profile on you. And if the three and all the companies look at your performance for cholecystectomies, gallbladder removal, you may be a 5-star in one and a 1-star in another, because the N is small and it may be large in another. If you had your own data, you tell them what your performance is. You don't have to be beholden to them. So yes, the ASCs and CONs will make more money absent of good regulation, and it is going to be dependent on the ethics of the providing physician. You can make a whole lot of money by doing inappropriate procedures, or you can drive value to society by showing outcomes and cost to be superior.
Thank you, Dr. Aluko, for those comments. Lawrence?
Yes.
Go ahead.
Yes, very briefly, thank you for this forum today. As a financial professional working with doctors since the 1998, in fact, in 2011, when the Harris County Medical Society started what is called the Friends of Society of the Medical Society program, I was the only financial professional that worked with them at the time. What we noticed is that in my team, I would have a team too of lawyers and tax planners and investment planners. So we have a division of labor. So for physicians, what you can look at, you need to have 3 specific goals. What are your personal goals, first of all, when you're looking at these things? Don't just look at the marketing portfolio that people present to you. What are your goals for yourself, for your business, and also for your family? When you look at that and you determine that, you can then narrow down. When you're bombarded with all this marketing material that financial institutions are going to bombard you with, you can then fit those things that will answer your 3 goals. When you do that, then make a choice of who your professional will be, which team you want to work with. And I find that doctors, when they do that, in spite of all what comes, they are able to narrow down to what they want to do. The other thing you may want to do is have a staff member in your office who, when these things come in, you don't get to see them. You have that staff member look at it, and if it fits into those 3 categories, then you give the appointment to work with whoever you want to work with. Hopefully that helps.
Can I add to that, if Stanley?
Who's speaking?
Owe Bell is speaking. Can I add to that?
Go ahead, Owe.
Go ahead.
Okay, yeah, I think that another element we have to be aware of is that the nature of estate planning, tax planning, and retirement planning, and all those various disciplines is that they all have one thing in common. They are a relationship business. You know, when considering engaging a professional, it should not be transactional. The professional should be looking to establish a relationship with you because they are going to go on the journey with you. It is not, they're not providing isolated financial products to you, flinging it at you and then going on about their business. They are supposed to be quasi partners with you in the trenches. And same thing with a respectable estate planning attorney. We go on this journey with you where you are learning about the various instruments and the various options you have available to you. There is absolutely no way that you would go into any lawyer's office knowing exactly what you want and how you want your plan to be. It is through disclosure of your assets, your circumstance, and dialogue that you jointly come together and draft a plan that satisfies your needs. And working with a professional that understands your unique background is also a plus because they will understand the importance of you having assets offshore, why you have them offshore, what your obligations are in Nigeria, even though you haven't been there in 30 years. So those are sorts of the unique things that are in your circumstance as Nigerian physicians in America. What you really want to focus on is building that relationship with that professional.
Thank you, Owe. I would have to end it here. It's been a wonderful webinar today. Lots of awesome, important information. We could talk all day, but throughout this year, we're going to continue the webinars. This is the first of the year. We intentionally made it long, but the subsequent webinars will be 1 hour, starting at 12 noon, the first Saturday of every month. I'm going to hold all the comments so that our national president, Dr. Chris Okunseri, can give us a closing comment. So we can go on and start our new year protocols. I'm sure you guys will be calling. I'm assuming Amy will be coordinating some of these things for some of our members. Personally, I wish I know now what I knew. I know, how do you say it? What I know now, I wish I knew it then. And I've done a lot personally, and it's had helped me to have a team to work for me. Chris, you can unmute yourself.
So thank you, Dr. Okoro. Once again, another excellent panelist your team have put together. And again, it's another milestone for us as an organization with all of these that we provide to members. I think, without going back to, summarizing what has been said, but I think I just want to touch on a few things. Dr. Aloko shared with us the big picture of our healthcare system so that it reminds us that we are part of a system. Yes, we have our solo practices somewhere, or we are working in a healthcare system, but there is a bigger system that we need to understand and help us plan as we go to this journey of our profession. And that moved on to Mark, who shared with us, the real interest for us about making sure that our retirement plans are well put together. That was closely followed by Hubert, the most wanted guy by the ROS, which I always like to remember him for, shared with us, the process. I think these are real value for us as members. And we moved on to Owe, who also shared with us the, estate planning. Don't wait for that thing to happen before you recognize that, oh, I have a will, I don't have this, I don't have that. So I think at the end of the day, I cannot say, I don't know how much thank you I can say to everybody, but I must say on behalf of the Association of Nigerian Physicians in the Americas, we thank you all for giving up this time this Saturday to continue to share with us your expertise. It is, to me, this is what some of us, or a lot of us without this, will go and pay consulting fee for. You pay some money an hour to get these guys to talk to you. So we are getting it from them directly. Again, so on behalf of our organization, I thank you all, panelists, thank you participants for showing up this morning to listen to these people, and we look forward to more exciting and productive webinar as we go along through 2021. Thanks, Dr. Okoro and the crew.
If I could just add one thing.